Welcome to the SCI Forum podcast. This podcast was produced by the Northwest Regional Spinal Cord Injury System in the University of Washington Department of Rehabilitation Medicine. The Northwest Regional SCI system is dedicated to improving the lives of people with SCI through excellent patient care, research, and education. To learn more about our podcasts and videos or to make a donation, go to sci.washington.edu. This podcast was taken from a live SCI forum. You can watch the video on our website or YouTube channel. Go to sci.washington.edu/videos.
Hello and welcome to the Spinal Cord Injury Forum. My name is Jeanne Hoffman and I'm a rehab psychologist here at the University of Washington in the Department of Rehabilitation Medicine. And I am the director of the Northwest Regional Spinal Cord Injury System here at the University of Washington. Tonight we are so pleased to welcome 5 wonderful women with spinal cord injuries representing a range of injuries and numbers of years since injury. And they're going to be talking about health and wellness issues that are unique to women. I think in our flyer, Cynthia put in about the fact that it's a minority within a minority. And I think there's a real unique set of circumstances that we want to talk more about. And so we welcome not only these 5 wonderful people's input, but also we'll be opening up at the end for Q&A and offering other opinions and ideas, and would love to hear your voice as well. We also are lucky enough to have on our panel Dr. Erica Bechtel. She did her rehabilitation residency here at the UW and is now the Spinal Cord Injury Fellow at in the Department of Rehabilitation Medicine based at the Veterans Hospital. So please join me in welcoming our panel. All right, so thank you guys all for being here. I just want to give a brief introduction here. Let me just start. Jill has been injured since 2000. She has a C4-5 injury and was 19 years old when she was injured. Sitting next to her in the middle is Erin. Erin was injured in 2013 and when she was 26 years old and has a T4 incomplete injury. Elaine, here at the end, closest to me, was injured at the age of 17, which was a few years ago. Maybe? Yeah. Just like 5 years ago. And she has T7 paraplegia. And then next to her we have Addie. And Addie was injured in 2008, and she has a T10, T12 complete injury. And then at our end over here we have Shannon, who actually is our kind of most recent injury, about 2 years ago when she was 33 years old. Thank you all for being here. I really appreciate your willingness to be on our panel and to talk about these kind of issues. And I thought we'd start out by really talking about kind of the healthcare experience. One of the things that we see on inpatient rehab is that many of the people with spinal cord injury are really entering healthcare for this first time, but women are often more connected with healthcare earlier and have more regular contact just because of the women's issues and gynecological issues. And so I'd like for you guys to just talk about what that access was like going from inpatient rehab back to whether you went back to your own primary care doctor or went to find primary care. How did you find the change in access in terms of both getting in and out of buildings and on and off of tables and those kind of things? And so Elaine, maybe could I just start with you?
Sure, absolutely. Well, my accident was in 1982, and so it was pre-ADA. The ADA was 1990. So things have changed a lot. It was, when you say to someone it was before curb cuts, they mean, like, what do you mean before curb cuts? Weren't there always curb cuts, or, disabled parking, or, back then it was big Chevy vans, that with like murals painted on the side, big loud lifts, and things were really different back then. Bathrooms were often not accessible, or just the men's room, was accessible. And so it was a challenge just to get to the doctor. So my accident happened in Puget, Washington, and Good Sam Hospital is there. So I had access to good care immediately, and saw my physiatrist for quite a few years after that, and got a referral to an OBGYN, and exam tables can be up here with no way, of getting on there, and having people help you, especially, it's different between, Addie's so tiny, and I'm just, I'm Eskimo. I'm an Eskimo in menopause, okay? So I do not wear coats. So if it's 30 degrees out, you'll know why, okay? So I just, I'm always warm now. So, but yeah, it's hard to lift dead weight, help, somebody. Now they have chairs that are almost like dentist chairs that you can transfer into, and it's a lot more convenient. But it does take a couple of people in the room with me, to do the well woman exam, which is, I was joking with you that, a pap smear should be a team sport, where, lots of people in the room to help hold your legs, so they don't spasm. And so I just find your happy place, and pretend I'm not there. And, but yeah, it's been a challenge, and I've seen a lot in almost 35 years of being in a chair.
A lot of change.
Absolutely.
Yeah. So, Addie, for you, did you go back to your primary care doctor, or did you have to find a new doctor?
I did. I kept my same primary care doctor, and she's downtown, so the building simply was accessible. Almost the exact opposite experience you had. They had 1 or 2 rooms in the back that have a lower table that then also has some elevation mechanisms to it. So that helps, and they just know now to, oh, she's coming, she gets the back room, even though it's a procedure room, not a normal visit room. That's been nice, so she's stuck with me.
Excellent. And you can transfer on your own?
I can, and it's low, it's almost an even transfer, and then there's a little bit of elevation if they need me a little bit higher for certain things.
That's great. Erin, how about you?
I also went back to my same primary care provider. It was a little bit of trial and error when I came in, because I don't think they really had a great understanding of how accessible their facility was. So they initially roomed me in a room that didn't have an adjustable bed, so they had to find another one, and it was a little bit of process of trial and error when I first came back to visit. And even getting in the building, going from just walking up the stairs to where's the accessible entrance, where's this, where does this ramp go? Her building is old and confusing, so even just all of that was a little bit of a struggle. But I was able, they did have a bed that was able to lower, so I could transfer myself. But there have been other medical facilities I've been to where I've had to ask for help just to get up, because they didn't go down low enough, or when I first got hurt, I wasn't as strong to do those off-height transfers, and so I definitely required more help or slide boards to get around. So.
Yeah. Jill, how about you? After you were injured, did you return to your same primary care doctor?
I was just starting with a new one, so I kept going to her, and I think my experience was kind of like Addie's. It was just kind of seemed really easy. I went inpatient at the University of Washington here, and so I just kept in the same system, which made it really easy to transfer to everything to that primary care doctor. Mm-hmm. And the building was easy, and most of the rooms just, they put me in the rooms with tables that go up and down, right, which makes it easier, but help transferring. Usually I bring someone with me.
Okay. So you kind of come with people to help you, whereas the rest of you guys typically go by yourself. Yeah. And so with that, has anybody at the doctor's office ever offered to help transfer, or is it just you kind of know that you're bringing your people and you're going to do it?
I usually know I'm bringing somebody who knows what they're doing. They offer the lift team, but that can be kind of uncomfortable.
Mm-hmm. Yeah, when you have a system.
Right.
Shannon, how about you?
I didn't have a primary care doctor at the time, so the Harborview staff, which is where I was inpatient, was really helpful in helping me find one. I think she was a little confused as to what to do with spinal cord injury, and there was no one there who knew anything about transfers, so when I go to see her, I either bring someone to transfer or don't transfer. I was a little surprised when I went to the Harborview Women's Clinic that they didn't seem to have any idea what to do since I couldn't transfer myself. So I have since learned that I either need to bring someone with me or be prepared to not transfer, or potentially train people on the spot how to do it themselves.
So you've been able to wing it a bit.
Yeah.
Yeah. Not ideally, but.
No, not ideally, but it's worked out.
You know, you bring up a really interesting point about how much your primary care doctor knows about spinal cord injury. Did anybody see a primary care doctor who had experience with spinal cord injury before you guys came into their offices? No. So I'm curious about how much of a role you all play in educating your primary care doctors to the issues that are important for you to be thinking about. So, Erin, how about, I'll start with you.
Well, I think I was fortunate to have a primary care doctor who was super gung-ho and excited. So when I came in, she had already done a significant amount of research into the types of issues that she needed to consider with spinal cord injuries. So she was kind of all over it. It was awesome, and I was excited to have her and have kind of that continuity of before and after, and her know my whole history, but also be all over the new aspects of my care. Yeah, and she ended up having to do some research to find me a urologist that she would recommend that could see me before I ended up going outside the UW system, because I was having a lot of issues with that right away. And so she found me someone outside the system that I could see and those type of things. So.
How about other people? Have you found, like Elaine, your primary care also didn't have a lot of experience. So have you done a lot of education over time?
Well, I have, because it was so long ago. And you just mentioned a urologist. I went to a urologist once, and the nurse who was helping me, she goes, "What would you do if you were normal?" And I'm like, "Normal?" I said, "What exactly is normal?" She goes, "Not handicapped." And I said, "Normal's a setting on a washing machine." Yeah, I just couldn't. I'm like, "You didn't have sensitivity training in nursing school?" I mean, it's like, really? And yeah, I actually ended up calling and talking to the doctor and, suggesting maybe they, have a training or something, because it just blew me away that somebody, would see something like that.
It doesn't really engender trust that they'll be able to answer your questions or help you at that point.
Right. It just, yeah. And I had a doctor ask me if my foot hurt, once after I told him I was a paraplegic. I was like, no, it feels great. Yeah, so, so it's just, yeah, it is. It's a learning curve. So I've been, almost 35 years, and my dad was trying to get my attention. And he's like, Elaine, and I'm like looking over this way, and I finally looked, and he's like tapping my leg. I'm like, Dad, hit my arm, would you? Do you not know after all this? Don't tap my leg, would you? So it's a learning curve, for everyone. Me too.
Absolutely. Shannon, since you're kind of the young one in the group in terms of years of experience with spinal cord injury, I'm curious about what that's been like for you to be with a primary care doctor who didn't have much experience and you being new. Have you felt like you're learning it together, or do you rely on your doctor to kind of know more than you, or how do you balance all that out?
Well, I can't say I spent a lot of time with her, but she was really helpful and clearly was interested in making sure I got the best care possible. She's been really willing to help me out without me coming in. So she'll do a lot of consultations on the phone, which is really nice. And every time I've asked her for something, a referral, etc., she's been really quick to give it to me quickly and or put one of her nurses on it. So generally, I was very glad that she was a female doctor. I think that was somewhat helpful with rapport and her willingness to do what she could. I think she's no longer my doctor, and we didn't spend, I didn't see her very often. So that's kind of unfortunate. I think it would have been nice to have a relationship with her before, but generally I thought she did a good job doing the best she could in the short period of time we worked together.
That's great. Does anybody have a male primary care doctor? You do. Now you do.
I do.
Yeah. I'm curious, Elaine brought up the idea or the discussion about gynecological exams and how many people are needed in the room in order to do that. I think all of you have said that you have gotten gynecological exams. Is everybody on the 2-year plan, 1-year plan? 2-year plan? Shannon's like, well.
Checking my watch.
Yeah, exactly. We'll see about that. Yeah. How many people in the room for you, Addie?
2.
Erin?
1, and now I'm down to 0. So,
Excellent. So
yeah.
you have figured out the key to the legs.
Yeah, well, it was interesting, kind of to tie into what you were talking about before. One of the things my primary care provider did do the first time I had a pap smear after my injury was, she was sat there and was explaining what spasticity was like and why the medical assistant was going to need to be in there to help with my legs, why they couldn't just sit in the stirrups like a able-bodied person's legs could. So it was interesting to kind of see the education in that. But I've had enough procedures at my urologist's office that I have figured out a way to hold my legs in a way that they won't spasm, or if they do, I can control them, and then I just kind of ball up. So yeah.
So it works. How about you, Jill?
Usually there's 2 other people
Yeah.
besides a doctor.
Yeah.
Well, I had 2 doctors and 1 caregiver last time.
Yeah. So 3's about the number. Yeah. So in terms of kind of the into gynecological care, managing periods is one of the things that comes up a lot for people of how do you and how do you not do that. And I actually am just going to go down because I find it interesting that everybody's done something a little different, which I think is really important. So Elaine, I know you mentioned you're in menopause, but you over the years have dealt with periods. So tell me about kind of what you've done prior to menopause.
Periods were really difficult for me because I self-cath, and sitting all the time is difficult with a period. So I just finally went on the Depo-Provera shot, which totally eliminated any symptom for me. And there could be, I guess, some side effects, and I've always struggled with my weight anyway, so that's probably one of the things. But for me, it was just easier to not have to deal with that. And they always made me take a pregnancy test before, and I'm like, can I sign something, please? Unless it's divine intervention, it didn't happen. Please, can I sign something? But so they were great, and it just was easier for me just to eliminate them altogether. So then I forgot to get one once, and then nothing happened, and so I think that's probably when menopause started to kick in. So they said, I eventually needed to wean off of those anyway to see if my body was going to start menopause anyway.
Right.
So hasn't happened yet. So yeah, it's been a good thing.
Good. Addie, how about you?
I've actually been more regular after my injury than I was before. I was a little more sporadic before. But so timing, it's a little bit easier to tell when they're coming. But I primarily use tampons, and then occasionally I'll wear a pad as well, just for leakage purposes, since you can't always tell when it's time to change, and it can vary time to time. So I pretty much just use tampons as a primary
And do you
means.
self-cath as well?
I do. So
Okay, so you're able to manage completely independently.
yeah.
How about you, Erin?
I use birth control, and I get my placebos, and so I get my period about every 3 months. I did that, one, because it's nice to not have my period every month, but also because I had like UTIs every month, and they usually correlated with my period, and so I kind of partnered with my PCP in the decision to in the attempt to reduce my UTIs, reduce the number of periods that I have. So that's what I do. And I self-cath and I use tampons. So.
And has that been effective to do the
Yes.
3 months? Has it cut down your UTIs?
Yes, definitely, yeah.
Excellent.
All right. For myself, I actually had early menopause about 10 years ago when I was 25. So, I mean, that's convenient for the period's sake, but it also, menopause is hard for like bone health, bone loss. And so on top of being, losing bone mass because of being in a wheelchair, the menopause has also affected that negatively. So I've had to monitor bone health after that more, but before it was tampons and yeah.
So before you went into menopause, and we'll talk some about bone health because I think that's a big issue. It's a bigger issue for women, even though it's big for everybody with spinal cord injury. But with the inability to kind of manage yourself, that was just something you had caregivers help you with?
Mm-hmm. Yeah, if my flow is heavy, then I transfer into bed maybe once or maybe twice a day. And then as it, slowed down, then I wouldn't have to do that so much.
And Shannon?
I was using tampons and pads, which is a pain since I couldn't manage it myself. So I ended up getting a 5-year IUD, and it's pretty much stopped my period, which has been fantastic.
Dr. Bechtel, I'm going to go to you and ask about, because I think that all of these different formats are all very interesting. And I think one of the things that I found interesting is that there isn't a one right method, and there's also some risks and benefits of different things. And so could you kind of speak to some of the risks and benefits of these different formats that people are using?
So, as Jeannie said, and of all you have demonstrated, is there's no right or wrong kind of way to manage your periods. And so, really, it's what kind of works best for you in terms of your function and assistance you may need, and just whatever you're most comfortable with. So, tampons, pads, skin concerns, you always have to think about if you have a pad and maybe you can't feel it, if you're going to have skin breakdown. If you're able to change tampons by yourself, that's great. I've heard of some women that use more of like the Diva cup or kind of the reusable sort of kind of menstrual flow catchers that are kind of easier to manipulate because they're a little bit larger. And I guess speaking to oral contraceptives, so a common misconception with those is that with a spinal cord injury, you could have an increased risk of blood clots. And that's, not any more different from a woman with a spinal cord injury versus a woman that doesn't have a spinal cord injury. Obviously, right after when you're injured, we do see a little spike in the increased risk of blood clots, for 2 or 3 months. That's why people are commonly on blood thinners, in the hospital while you're in rehab. But after that, a person with a spinal cord injury's risk of getting a blood clot is no different than someone that doesn't have a spinal cord injury. So even though women, there is, your PCP should still counsel you if you're going to be doing oral contraceptives on the risk of slightly increased risk of having blood clots, especially if you have a family history of them, but it doesn't mean that you are at a greater risk of having a blood clot because of that. IUDs are a great option. The only thing you have to think about with that is if you're insensate, if there's ever, they have such a small risk of perforating or causing some sort of intrauterine infection, would you be able to detect that? And eventually that would just kind of reveal itself with time. There's no really way to prevent that. You just have to be vigilant. If something is off or if you have autonomic dysreflexia and you can't figure out why, that to always kind of remember that there's, the IUD and that other healthcare providers are aware of that if you're seeking help with that. Depo, there's really no difference between, an able-bodied person or a woman with a spinal cord injury in terms of risks or benefits with that. And again, there's no reason that a woman really has to have a period. So if you're, skipping the placebos, that's fine. Was there any of them that I forgot of kind of method of management? While we're on this topic, after spinal cord injury, often women may, lose or stop having periods for a few months, maybe up to a year, but generally they return after that.
Thank you. So I think that's interesting that there's really a lot of difference. And I guess, Shannon, one follow-up question with you is that was there any discussion or concern about autonomic dysreflexia when they placed the IUD, or did you guys discuss that, if there was any concern about that?
Mm-hmm. I talked to my spinal cord doctor about that. Of course, the doctors at the women's clinic at Harborview didn't they don't even know what autonomic dysreflexia is, so they had no concern. But my spinal cord doctor did have some concern around me using oral contraceptives for blood clots. I suppose I was relatively new at the time, but she seemed to have long-term concern as well.
It hasn't been studied, I would say, a ton in women in spinal cord injury, but the studies that they have done haven't shown that there's a long-term kind of increased risk. So,
because there hasn't been enough research, there hasn't been enough done, that people go to the side of being cautious sometimes, rather than kind of thinking about quality of life issues as well. So I think it's always that balancing act of kind of knowing what to monitor. And I think all of you guys who are doing some sort of birth control all talked about kind of what you did to monitor, what you do to kind of keep track of what's going on and making sure there's no issues, because it is different. It's different than what somebody else who has sensation in their legs, for example, would be able to do. So that's interesting. Now, in terms of, Erin, you mentioned the kind of correlation that you found between UTIs and your period. Did anybody else have that issue where they had increased UTIs around the time of their period or not? Because I think that is one of those
frequently, but there hasn't been an exact correlation, but I do get a lot of them, so there's that.
Yeah, something to start paying closer attention, collect some more data, or something like that. So you brought up, Jill, the issue of bone health and osteoporosis. And actually, maybe we could just kind of go through and talk about, because I'm sure that's been a topic everybody has at least had some discussion with their doctor about. So I'm just going to start with you, Shannon. Talk to me about kind of what you're doing or what you're thinking about in terms of osteoporosis and bone health.
Well, I had a bone scan, and I don't remember my numbers, but I remember that they weren't great. And that was only a year or so after my accident. And I got the bone scan so I could start going to the gym. And then I met with my doctor, and I said, well, how do these numbers look to you? And she said, well, they don't look great, but even when they're really bad, we don't have anything to tell you. So go ahead, go to the gym, have fun, and good luck. So I wasn't quite sure what to do with that, but, I thought, I guess it's better to stand when I can and do what I can to stay healthy.
So do you use a standing frame?
Not as often as I should. I try to do it once a week, but that doesn't always happen.
So that's kind of your major focus right now, is being active as much as you can and standing occasionally, and then keeping track, doing the scans.
Who knows what my bone health was like before? My doctor would never have recommended getting a bone scan previously, so it's really hard to tell what kind of, what a year, what 2 years, what impact they had on my bone health. So.
Yeah. So Jill, how about you? I mean, obviously going into early menopause, that kind of triggers all of this even more so, I would imagine, for you. So can you talk a little bit about kind of what you've tried and then what you're currently doing in terms of kind of managing bone health?
Yeah, I had a standing frame for a while, but it just wasn't practical for me to do it enough to make the benefit of the struggle worth it for the benefit of my bones. And I do have a regular DEXA scan once a year, I think. And I also did a shot called Forteo, which I did, I think, a daily shot for 2 years, and then was off of it for a year, and then they kind of reevaluated my bones. And I think there was no loss in the bone density, but there wasn't any gain either. And now I took calcium for a while, but a few of my doctors have said that taking calcium in supplement form isn't as necessary as they thought it was at one point, and just getting it through food sources, natural ways, can be just as or better way to do it.
So right now, the kind of combo that you use to try and maximize bone health is vitamin D. Is that what I remember?
Yeah, I do take vitamin D. I also take estrogen and progesterone. And so the hormone balance is helpful also for bones.
Mm-hmm. Erin, how about you?
I had a bone scan probably about less than a year after my injury, and I think I had, what was it? Some sort of osteopenia. I was in the osteopenia range, and met with an endocrinologist who gave me some recommendations that I follow. I take vitamin D, I eat quite a bit of dietary calcium, I lift weights, I'm active, I have a standing frame. I'm terrible at using it, but I have one that makes me feel guilty when I look at it. But anyway, and I'm supposed to go see a doctor about it, but I just haven't gone. So I'm not the poster child for bone health, I don't think. I don't know, part of me is a little resistant to go gung-ho into every medical recommendation that's made. I try to balance it with my own life and work and hobbies and all of that. So
I've had probably 4 bone scans about once every 2 years, and from the beginning was about less than a year after injury. And I was already at the bottom of the osteopenia, borderline osteoporosis, which everyone has gone down slightly. So being younger when I was injured, I again also don't know what my bone health was like before. They're guessing it was fairly low just naturally. But my doctors have been hesitant to put me on things because we don't know long-term being so young. But I'm currently in the discussion of, well, what are we going to do? Do we do something cyclical and see what happens, like Jill, or try something and hope it works? I don't know. I don't like to take a lot of extra meds if I can avoid it, but I also don't want to crumble by the time I reach osteoporosis and then really drop off and transfer and fall apart. Like, that's not something I want. So
working on it.
Yeah, it's a discussion in process right now, that's for sure. And I too have a standing frame. I haven't used it much the last probably 7 years because my hips are so tight that I don't go, and my knees too, I don't go straight anymore. So it's very uncomfortable and painful, which makes that all harder. And I do the stretches I can to try to prevent more of that, but it's kind of a catch-22.
Absolutely. Elaine, how about you?
Yeah, when I was first injured, I had a standing table at home, but it required someone to help me, so it wasn't an automatic one or anything. So now they're really fancy. But yeah, they kind of end up being a coat rack after a while.
It does sound like a dust collector for many.
I know, it does, yeah. So I probably would be afraid at this point in time after almost 35 years. And I have a friend with spinal cord injury, and she has broken both legs, several times, and I try to be really careful about that. I was adopted, so I didn't know my family medical history, but a couple years ago I found my birth family, and my birth mom had died from complications from MS, multiple sclerosis, and so my doctor told me it's really important that I take vitamin D supplements. It's something to do with lack of sun, so I take the calcium D supplement together. I've been lucky, so behind in the scans though, for sure.
Dr. Bechtel, is there any kind of standard advice, or is what we're hearing kind of what is the advice you give?
So bone health is always a very important topic, but it's one of the topics that frustrates me the most because we don't have any good recommendations. And I'm sure just with the heterogeneity of what all of you are doing, I think that echoes that. And so in terms of standards, there's been, all these studies, and they put them all together, and they say, what evidence can we say on bone health? And the verdict on standards is that there may be some benefit if you start standing immediately after your injury for like 90 minutes a day, every day, for the rest of your life. Like, as long as you sustain it. So that's pretty, that's unrealistic for, everybody, right? And that is even a maybe benefit. When they've looked at people that have chronic injuries in terms of standing and bone health, there's many other benefits to standing. But in terms of bone health, it hasn't really been very impressive, which is unfortunate. And although this wasn't your question, I'm going to throw it in there. But the topic of kind of DEXA scans and medications, and those are usually bisphosphonates, or the type of medication. So they're either the pills, like Boniva, the commercials, or the shots. And so, there's tons of studies on those in able-bodied women that are postmenopausal, and they say that this works well for preventing fractures. mostly in women's spines, which is not where women with spinal cord injury tend to fracture, or men with spinal cord injury tend to fracture. And so many studies have been done on these medications in folks with spinal cord injury, and also nothing has really come out of that they're of any benefit. And they've tried right after injury for a little bit, for a long time, later when you're injured, if you kind of do a cyclical or a pulse, and nothing has ever said that it either helps or doesn't help. And these medications aren't without side effects either. And so the hardest thing that I often have to deal with are DEXA scans and what to do with them. Because they're, as you said, they're always going to be low numbers. And these numbers are compared to, I think, like a 30-year-old woman is kind of what these numbers are in relation to. They measure basically your spine, the bone density in your spine and your hip, which again is not the most common place people fracture with spinal cord injury. It's usually like in your femur or your lower leg. And so we don't know, if they're not even measuring those areas of that bone density, can we like extrapolate here to there? And so it's very hard, and oftentimes DEXA scans are done in preparation for someone to go to the gym or to start standing, and we're like, well, it's so unhelpful because we're like, well, we don't know what number you may or may not fracture at. Everyone's different. We have no idea. We can just kind of counsel on the fact that your bone mass is probably low. There's a risk of fracture. Yeah, be careful. And so it's not very helpful most of the time, so it really frustrates me. But unfortunately, there's just not good evidence or data out there. So that's good. So the guidelines for population as a whole is that if someone is at risk for having osteoporosis, they should have adequate amounts of calcium and vitamin D. So I think that if your vitamin D blood test is normal, then you shouldn't need to additionally supplement. You should just keep it, above 25 or 30, whatever your doctor's cutoff is. And calcium, you're right, the newer stuff is saying that supplements aren't as good as dietary sources, but just still getting the recommended kind of daily allowance for an able-bodied person. There's no specific numbers specifically for the spinal cord injury population. It's just...
Thank you.
The other couple topics, I'm going to actually, Elaine, you're my person today because you happen to be the only one who's of an age to be thinking about mammograms in our group here. And also interested in talking a little bit about your kind of decision about pregnancy and kind of going through that process, because again, you're the only one on the panel who's had a child with spinal cord injury. First of all, mammograms. You have them.
I do.
You have them seated.
I do have them seated. Yeah, it can be kind of a challenge to get to the right, level of the machine. And there's a place near where I live, the Carol Milgard Breast Center, and it's kind of like a little spa where you wear a little robe and has a little locker, and so they try to make it as pleasant as possible, but you still know what's going to happen. And so
just in case you didn't know, they really do that.
Yeah.
It just squish.
Yeah, I know. So, and it's awkward, and I have to kind of scoot to the end of my chair, and the female technician kind of places you into the into the machine, and hold your breath, and it's not ideal, but it does work.
Did you have to call around a little bit to find a machine that you could use? Because I know that that's been an issue, that there's sometimes machines aren't available if you can't stand.
This is a pretty new center. Yeah, they've, by the time I was at the age where I started getting mammograms, that was the place to go. So they've been more than accommodating to me. And they've said before, maybe don't come on a Saturday, come where, we have more people and during the day. And so it's just getting on a regular schedule, like, any annual type appointment. So it's a necessary thing. My son gets on me, Mom, have you had your mammogram? Yeah,
He's well trained.
I know.
Good for him.
Yeah, I have two friends here today that have both had breast cancer. Yeah, mastectomies, and so it's like, really, isn't one disability enough? Do we had to have breast cancer too? So yeah, I've learned a lot from them. It's a very important thing to do, no matter if it's uncomfortable or what. It just is a necessary thing to do.
Excellent. So switching then to pregnancy.
Yes.
How old were you when you decided to get pregnant?
I was probably about 32. I had been married for 7 years. I'm sure people thought I couldn't get pregnant because we had been married for that long without having a baby. And I was married to a musician, and kind of the nightlife of, and just, I had won the Miss Wheelchair America pageant and had traveled for a year. And when I came back from that traveling, it was about 4 times a month on a plane. I was ready to stay home, and I really felt like I was ready, as far as just the time of my life. And so I went to see an OBGYN, a specialist that was recommended by my primary care physician. Yeah, he had no bedside manner at all. And he said, when I first heard, someone with a spinal cord injury would want to have a baby, I thought, who would be that stupid? And I'm just like, I know, I sound so negative, don't I? I don't mean to sound negative, but I'm just the things that people say sometimes. It was one of those things like you get insulted, but you don't realize it till you leave. Just like, did he just say that? I don't know if you guys have had people just say things you're like, whoa, yeah. But he was good. He was recommended. I absolutely trusted my doctor, and he did he was great. I mean, he really knew what he was doing. He just, like I said, the bedside manner part was not there. But they said it could take 1.5 years after being on depot for so many years for me to get pregnant. And I got pregnant 1.5 months after I stopped depot. We're like, did we drink off the same glass? How did that happen? Yeah, and so it was kind of a shock. I needed to take a medication, and the doctor said, don't take it if there's any chance you're pregnant. I'm like, well, I'm not, but I'm take a pregnancy test. Big blue plus sign. I'm like, wait, that can't be right. Yeah, I called my friend Melissa. I said, oh my God, what the heck just happened? Yeah, it was kind of a shock. I just didn't expect it to happen that fast. I didn't trust a home pregnancy test, so I wanted a rabbit to die. I needed to know for sure. I need a blood test. I don't trust these home pregnancy tests. And so we went into the doctor and had a test, and then had to wait till 5 o'clock that night for them to call and tell us that yep, I was pregnant. And so my husband threw up first. Yeah, he was the first one. He threw up and then cried for a half hour, and then we were just both sort of in shock, and it was quite a journey.
Yeah. So you obviously grew along the way. Yeah. Did you just find that you accommodated with transfers and things like that, just as you kept getting bigger with the baby, that you just could adapt pretty well?
Well, I've always been heavier to begin with, but I only gained 14 pounds, and my son was 8 pounds 3 ounces when he was born, so I didn't really gain a lot of weight. Plus, I was sick as a dog for 9 solid months. I just was nauseous. I couldn't go anywhere where there was Chinese food, or I would die. You have like these superpowers, for smell. The one time you can eat it, I couldn't eat. Yeah, I was just pretty much
one
nauseous.
of those unfortunate people who has 9 months of morning sickness.
Yes, exactly. And had a boy with lots of hair, so I guess I don't know if that's true or not, but I could only eat sour things. He wanted, Satsuma oranges. Transferring was a little difficult. My ex-husband is blind, so I still doing all the driving and everything, although he did have to back out my car a few times. I'm like, I'm not even telling you where the gas pedal is. Brake only, because he had this big Cheshire grin on his face when he get behind the wheel. So we were quite a couple. Yeah. And we laughed so much because, to have a 6-month-old baby be the most able-bodied person in the house, so yeah, it was pretty comical. So yeah, him changing a diaper, not even going
not
there.
Not really helpful.
Yeah, really, yeah.
So with your pregnancy, did you have a C-section? Did you have natural childbirth?
I had natural childbirth. Yeah, they scheduled me to be induced because women can go, into labor and not even know people with paralysis, spinal cord injury. So I was scheduled to be induced, but the minute I hit the hospital bed, I started having my own contractions. It took a while to get dilated. I got stuck at 9. They gave me a little drip of Pitocin. Yeah, but once I was dilated, it took 14 minutes. My best friend, Melissa, was with me, and she's like, this should hurt you. Yeah. I'm like, hey. Yeah.
So supportive.
Yeah, I know. But they gave me an epidural because of the dysreflexia. My body would sense the pain and fight it, and I could have a heart attack or stroke. So They wanted me to have my body relax and not fight the pain. But toward my third trimester, I was giving myself heparin shots to avoid the chance of blood clots. Yeah, getting around was a little bit of a challenge, but it was really a great pregnancy and a great experience. Yeah, he's definitely worth it. He's almost 18.
I know,
right
isn't
now.
it amazing?
Yeah.
Erica, did you want to add something about pregnancy?
So anything that I would add, and a lot of it I think I'll just echo Elaine. So the ideal situation is not a surprise pregnancy, just because many women with spinal cord injury are on medications that may not necessarily be recommended, I guess, in pregnancy. And so the biggest ones that come to mind are spasticity meds. And so baclofen and tizanidine and dantrolene are kind of in this gray zone, what we call like, all meds are rated like pregnancy risk. And so those are C, like we don't know. So you're like, thanks, that's really helpful. And then Valium or any other sort of benzodiazepine is contraindicated in pregnancy. So that one's a solid no. Pumps, we think are okay, baclofen pumps. And even if, I believe, if you really had to get Botox during your pregnancy, then that is also okay. There's one other thing that I wanted to add, sorry. Some other medical concerns that might pop up are autonomic dysreflexia versus preeclampsia. And so preeclampsia, and granted I'm not an OBGYN, but I think it pops up more in like the third trimester, and that's when someone is hypertensive kind of all the time versus just sporadic autonomic dysreflexia. And so going along with that is trying to find an OBGYN that, one, is well-versed, hopefully at least had a few patients with spinal cord injuries, or is considered kind of like a high-risk OBGYN just in case. And as Elaine said, you had a vaginal delivery that's actually pretty common, which I was actually surprised when I was first looking into this. I thought the C-section rate would be higher, but it's kind of like a third. So a third kind of spontaneous vaginal, a third assisted vaginal with like the sucker, or another third cesarean. But generally everyone has spinal anesthesia as well. So I think that's all I wanted to add.
And if there's other questions that come up, we'll have time at the end to do that. I do want to ask about kind of being a woman in a wheelchair and what, kind of things you've had to think about in terms of self-image and self-esteem and kind of feeling sexy and attractive and all those kinds of pieces. And so I'm just going to start with Addie. Addie, what has been, I'm just picking randomly. Yeah, you don't have to talk about sexy. You can talk about self-esteem and self-image and kind of what has been the process since your injury about kind of getting there to being comfortable, or are you?
I am. It is a process. I would say I've probably been around the whole block twice. You start off, you don't even know your body anymore, let alone how are you supposed to be proud of what you don't know and what's different. And I was all legs and butt before, and I am no longer any of that. So relearning how to be me in a way physically. And I was 4'11", I am shorter now, but still, everything is new and different and a little bit crazy. And for me, a big part of gaining my self-confidence back came through eventually getting back to my routines that I was doing before. I was going to school, getting back into school, eventually getting to work, and kind of, in a way, proving that you're the same person even though something major has happened. A lot of people kind of see you different at the beginning, I feel like, or are just too afraid to ask questions. You're like, dude, I'm still me. Like, let's move on. And so in kind of dealing with all that stuff the first few years and whatnot, and that getting what I considered me back slowly eventually led to more self-confidence over time and not being as ashamed of my bony legs and scared of being crazy. Let's just put it that way. But yeah, no, I do feel like I have pretty good self-confidence, and may not like to go into a room where I know nobody. It's just never been something that I've wanted to do, but I do social things. I like my own alone time as well, and I still feel like there's a very good balance to who I am, which is very similar to before, and staying active and just doing what I consider to be things that I liked before as well, as much as I can. And so then I guess with self-confidence comes some of that sexy part. So not every day do I wake up and go, this is sexy. But there are days and there are, times and whatnot. I feel like that usually takes a little bit more effort on my part. If I don't wear those, I woke up looking like this shirt's like, so no.
All right, Erin, how about you?
Actually, my experience is kind of similar to Addie's. Before I got hurt, so much of who I was physical. I was I was very active. My job was physical. The things I did with my friends, running, working out, backpacking, climbing, all of those things were who I considered was me. So to lose that after my injury was huge. I felt like not only did I lose my physical appearance in a way, but I also lost who I was in kind of how I defined myself. And so that was a really big challenge. And I don't think I'm fully 100% owning this every day all the time, but I think I'm better. And I think a big part of it for me was finding a new way to be physical and be active in my new body. And so I do rowing, and I found a way to feel competitive and work out really hard and feel strong and have something to work toward, and that has been tremendously helpful for me in getting my confidence back. I also think getting back to work, getting a sense of accomplishment in that environment was huge too. Another thing that I did that was more recently, but I felt like really helped, was before I got hurt, I don't think I've ever been someone who had like a super awesome self-esteem. Before I got hurt, I wasn't very confident, and I was always comparing myself to, whatever perfect person was on whatever magazine or anything like that, which is not very productive. And so recently I started reflecting on that and how I could kind of change my comparison or change my context. And so this is kind of shallow and silly, but one of the things I've done is I've started to follow like a bunch of women on that are chair users on Instagram that are all like super beautiful. There's some really awesome, there's this tennis player I follow who's like this amazing, like beautiful Brazilian woman. There's all these photos of her like on the beach in her chair, and she's super strong. And so I've been trying to surround myself with images of that, and I feel like that's really kind of helped reset what is normal or what is beautiful to me. So,
well, that's a great idea.
Jill, how about you?
I think it's been a process. After my accident, I was very physical and active before. I rode horses and just all sorts of sports. And so after, I tried to continue with the things that I loved, but still do them in a way that I could. Tried horseback riding for a while and was really emotional. That was a great experience, but I also went back to school. I got a degree, and I think that was really good for me to kind of force myself to be in a social situations, which sometimes I have to force myself to do because it's easy just to, kind of keep to myself, and that never proves to be very beneficial. But I'm really looking forward to expanding my social circle to others who have experience that can help me, and I think that will be, really good for me and my self-image and self-worth.
Absolutely. Shannon?
Well, I would say I still am working on it, and it's lovely to hear from all of you. I think I described it to you as a sort of second adolescence, which I wouldn't wish on anyone. It's a lot to get used to. I think as women in society, we are already faced with a lot of challenges in accepting our bodies, and this is an extra special challenge. I was also really active. I was a big biker, and that was a big part of how I identified myself. So it's a process of sort of getting to know myself again. It's been really helpful for me in getting back to school and working I used to go dancing a lot with my friends, and my friends sometimes take me out dancing, and that's really awesome. I don't think I'm quite there yet, but I think meeting a lot of other really strong, cool ladies has been really helpful. And I know that I'm the same person, and that sometimes that almost makes it harder. The more normal I feel, and yet my body is not the same. I think that's kind of the stage where I am in my own process. I think I love myself, and that work is really helpful. But I also think that a lot of things that I dealt with in my adolescence are helping me in this process as well, Those girls in the magazines are photoshopped, and just because you're able-bodied doesn't mean you're sexier. So I think it's a process.
Absolutely. And Elaine, how about you?
Well, I was injured when I was 17. So, and it sounds weird, but I always thought if it had to happen, that was a good age, because I was ending high school. It happened at the end of my junior year of high school, so I was in the hospital for 6 months, back when they had long rehab stays. So I finished high school in a wheelchair. I didn't start high school in a wheelchair. And your life changes so much after you graduate anyway. And I lost pretty much all my friends, which was hard, but they were my kid friends. And so I met my adult friends later, and met my friend Melissa in 1990, and we just sort of connected. We were like, oh, you have big hair and you love to shop, yay, yay. And she really, she was graduating from PLU, and it just, she was very driven, and made me want to go to school.
And Melissa also has a spinal cord injury.
Yes, she does. Yeah, she does, yeah. A couple years longer than I have, and she taught me a lot, and so education has also been common. I really see education as freedom. It changed my life. Really, I had a horrible math and test anxiety, and so that was my Mount Everest to climb. I've always had some self-esteem issues as far as my weight, so I think that bothers me more than being in a wheelchair. My wheelchair doesn't stop me anything, but my weight does. I can, if that guy doesn't like me, it's because of my weight. I can blame it, and it's the one thing I can control too, which is crazy. I have struggled from depression too, and so I take antidepressants, which helps me, and also always trying to have something to look forward to, is something that I've planned or something that I know that I can look forward to. It has helped me a lot. I've been divorced since, we broke up in 2000. So it's been 17 years, and dating in your 50s is ew. So it's been tough. My dog Benny's my significant other right now. I'm just no drama, unconditional love. I just have a lot of friends, a really great core of women friends, a lot of women in chairs. Friends can be your soulmates too. It doesn't have to just be one person. And I co-parent with my ex-husband really well. Yeah, my son, he and I have been kind of a world of two for a long time, and he's been my main focus. And he's surprised that I ever dated, and I'm like, well, yeah, you weren't part of it. And I have had lovers over the years, and people are like, really? And I'm like, yeah, geez, yeah.
Typical 18-year-old boy with his mother, right?
Yeah, really, I know, going, blah, yeah, don't tell me. Yeah, and people seem to be surprised that you would have dates and lovers. It's just not dead.
Right. Still all works.
Yeah.
Absolutely. I want to give opportunities for people to ask questions, but I have one last one for everybody. Whoever wants to start can pick, in terms of what advice would you give to somebody, a woman who's newly injured now? What kind of advice? What did you want to know, or what would you recommend? So who wants to start?
Don't diet. I swear to God, don't diet. If I could go back then, when I was 20, and just hug that girl and say, just right the way you are. And I've been yo-yo dieting and did Nutrisystem and lost my gallbladder. I was trying to go by these weight charts that are so unrealistic. And if I could just go back to that 20-year-old and hug her and say, you're just fine the way you are. Just don't starve yourself and try to be this person. You're not, and it's not healthy anyway. Like you were saying with the, comparing yourself to able-bodied women, By the way, I thought if I looked like you, I would have no problems in the world because you are so beautiful. Oh my gosh.
See how it is? See how it is? It's all about comparison.
Look at Jill's skin. She has the most perfect skin. Oh my God. So yeah, it is. It's all relative. So yeah,
That's an important one.
It is, and just try not to, the comparison thing. I got my body image epiphany from watching Kung Fu Panda. Yeah, because I did, because they're making fun of him for being an overweight panda, but they're comparing him to a snake and a grasshopper and a tiger. And I'm like, don't we do that? We do that. And I'm like, I am never going to be a tall, leggy blonde from Sweden. It's not going to happen, but I beat myself up over it. So so I have to thank Jack Black
for that one.
Say thank you for that.
Addie, how about you? What advice would you give?
Oh, there's a lot. I would say take it slow and one day at a time. So much is different, but as you find out what's different, learn how to cope with it, and then not even necessarily be okay with it, but find a way to look forward to the next day. Because at the beginning, it can be really, really hard, and you don't even feel like you. So I would say probably take it one day at a time. And it's okay to have bad days. Even now, we all do. So, and they are okay. Just as long as they're not every day. Then you might need to do something about that.
I actually have a friend that I've been spending time with who recently had a spinal cord injury, and my relationship with her has just been so awesome for me. But some of the things that we've talked about is like, it gets better, and it does. You feel like you're totally out of control with every part of your body, and you figure out ways to make it work and make it manageable. And I think the other thing too is to, at least for me and for this friend of mine, it's so easy to think about all that you've lost, like sprint toward getting everything back, which I know I did. And I think it's really important to give yourself credit and for what you've been through and the really difficult challenges that you're facing, and to just go easy on yourself, because it's a lot. And just remind yourself, this is a big deal. You're doing awesome here today. You're doing stuff. This is great. And I think that's a great way to start. So.
Great ideas. For me, having a sense of humor, I think is so important, because sometimes all you can do is just laugh it off, because you don't have control over so much that you did before. And I think that's really key to keeping sane, is just being able to laugh. Yeah, and keeping a perspective of today might really suck, but tomorrow has a possibility of just another day, and it can be a lot better.
A very practical piece of advice, which I actually got from Julie one time, was that cranberry D-mannose is great for UTIs. I wish someone had told me that the day after my accident. And a little less logistically, just be patient with yourself and know that you will figure things out, but it will take time. I think that's one of the hardest things to remember, is to just be patient.
I have something else to add. Two more. Kind of building off of what you said, have fun. Find a way to have fun, and it's okay to ask for help. I was very, very independent before, and learning to ask for help again was something that I really struggled with, but it is completely okay to ask for help. So it's always something to keep in mind.
Great advice. I'd like to open it up now for questions. We'll take questions for a little bit, and I know everybody was willing to answer a few others once we get past the hour as well. But any questions? Do you mind taking that one?
No, I'll be happy to.
See, I'm randomly choosing.
So I have dated since I actually was in a relationship when I got hurt, and we continued our relationship for a period of time after my injury. And then I've dated I've been in a couple other relationships that were kind of they were like less than 6 months. But I've done online dating. That was how I met the last guy that I dated. And I actually this is advice that I got from a friend that I thought was great, so I'll pass it along, for how to handle the whole dating. People here probably do have different perspectives. how to handle the whole, how do you set up a dating site? How do you make your page when you're in a chair? How do you deal with the chair? And my friend had recommended to me to not have the chair in the first picture and then to have the chair in subsequent pictures, primarily to not draw creepers in the first picture, and then and also to highlight, like, it's a part of me, but it isn't me. And so I try to do photos of me hand cycling or fishing or dancing or whatever, to try to show perspective versus just, hi, I'm in a wheelchair. So that's kind of how I handled it, and it seemed to be worked fine. Nobody ever was surprised when they saw me. Some people right away gave clues that they were going to be weird about it. So it was really, it was easy to kind of just brush them off. If people bring it up right away and make a big deal about it, not interested. So it wasn't actually that bad. I don't think it was. I did an internet date before, so I don't have a comparison, but it seems okay. I mean, it's like not that fun. It's a lot of work and messaging and dates and all that. It was fine. Yeah. Is that it? Did I cover it? Did I cover your question? Okay. Yeah.
What do you think would be helpful for other women to know?
Yeah, and some people are really great about it, and you run into total jerks who would have been jerks regardless, and you run into people who are really great, and you end up having a really fun time on dates with them, and things that you think would be a big deal aren't as big of a deal as I would have thought. So it's not so bad. Yeah.
Can I say? Oh, something I never was aware of, but my friend Meg was actually the person who told me that there are people called devotees that have a thing for women in wheelchairs, and it could be a man pretending to be a woman in a wheelchair, trying to get to know you, and it's really creepy and weird. And you do have to be really careful about that. So I had no idea that was even, till somebody friended me on Facebook who turned out to be an able-bodied man who pretended to be a woman in a wheelchair. Yeah, it's scary. It's scary because we are vulnerable. And online dating, I mean, of course, like anybody, you have to do, in a public place and tell people where you're going and, what you're doing, and make sure that you're really safe about it.
Other questions? I guess one other question I'm curious about from any of you is just how much are you having to explain to people out in the world who don't have spinal cord injury about what it means to be in a wheelchair? Does it come up when you meet with friends or when you're at school, or does it come up at all?
So I had this question. I'm a graduate student, but I also teach. And the first time I went into my classroom, I was nervous about talking about it, but I addressed it the first day. This is my third class now since my accident, and I addressed it the first day. I always remember to tell my students that I can't use my fingers. And I found that my students are really awesome about it. They help me do things that I can't do, and they make it really comfortable for me, and I think for them it's also a learning process. And I hope that the next time they see someone in a wheelchair, it's a little bit more normal to them. But it's been a really positive experience for me when I wasn't necessarily sure what to expect, and I've been really pleased with how awesome my students have been and how accepting and range. They're college students, okay. So most of them are 18 to their early 20s. I have some adult students.
It could be from anyone, including therapists. What kind of thinking is there behind getting a catheter versus having urinary and or bowel incontinence?
So 3 of you guys self-cath. What do you guys do for bladder management?
I have an indwelling catheter.
Indwelling catheter?
Mm-hmm. I use a suprapubic
catheter. So incontinence really isn't an issue because you guys work on a schedule for cathing, and for you guys, you kind of go as you go into some sort of either belly bag or a leg bag. Did that answer your question?
You were asking about incontinence, though. Every once in a while, like if I do have a UTI, that's one of my things is I will leak a little bit sometimes. Or if I have a cold with the coughing, it's a game over. It's just a fact. Other than that, in day-to-day, I've learned hot coffee, not so much tea, but hot coffee is, oh boy, you are gonna have to go, and you're gonna have to go a lot right now. And if you don't, you're gonna have a problem. So not drinking hot coffee in public is a good thing for me. So,
So do you, when you have a cold, what do you do when you know that like this is going to be an issue and you still got to go to work?
well, I try not to go to work when I'm sick. I don't get sick often, which is nice, but I actually will get like the super long overnight pads and just put those in, like my underwear, because I don't like the whole diaper thing. And then you are changing your sheets a whole heck of a lot less, even though you're still getting up to go to the bathroom. It does cut down on the laundry a lot. Yeah.
No, I always have slept on a pad, just a washable, like a crib pad, just on my bed. So I don't sleep without those because maybe it's just peace of mind, but I have, had accidents. It's just part of the deal. It's when you self-cath especially. And I just try to be really mindful of the time and every 4 hours. And if I do, I can't drink black coffee either. And so you just have to know, all I can tell is my face gets really warm and I feel kind of full. And so I have to be really mindful of my body's signals of saying, hey, my doctor said if I can tell those signals, I've waited too long to cath because I shouldn't get those kind of signals.
My bladder is has a mind of its own and is a little, I've done a couple different, I've taken meds and I've done Botox and I'm back on a lot of meds. It still is kind of spazzy. So I pretty much always wear not a pad, but like a urinary thing. And I sleep with a pad on top of my bed so that I can wash it, and it's not great, and I know I'm probably biding time for some other type of solution, but it works for now and it's fine.
Another thing for the newly injured person, don't ever take your skin for granted, ever. Just, it's something you always have to be mindful of, and because once pressure sores start, it's a nightmare. So being really mindful of that kind of thing is huge.
Yeah, monitoring incontinence. Dr. Bechtel, can you speak a little bit about kind of other things that people might be thinking about in terms of kind of managing incontinence to protect skin, to kind of protect comfort? I mean, obviously being out in public, you want to be continent both of bowel and bladder. So other things that people need to be thinking about or doing, any other suggestions or ideas?
Yeah, so I guess bladder management as a whole, the few things we really want that our goals are, one, protecting skin, and I guess two, making sure that you're emptying your bladder in a way that we're not going to be causing kidney damage, right? And so that can be variable for many people, whether, some folks with spinal cord injury don't need to even cath or have a Foley and they're able to void on their own, as long as we know that, you're emptying your bladder all the way and you're not having these high pressures that are causing kidney damage. And so it really is, pretty variable from person to person. And I think women in general too, just because with our anatomy having shorter urethras, which can set you up more for UTIs, and also just kind of access issues that men, don't have with their urethra. Having issues with urethral kind of erosion can be issues with women with an indwelling Foley, so some will go to a suprapubic or with intermittent cath. I think that whatever system allows you to empty your bladder in a way that is manageable for you, also while minimizing skin breakdown with incontinence episodes, is really the ideal situation, and for every person it's going to be different. And as you mentioned with, meds or Botox are often options, but also not amazing options all the time. So, and then bowel incontinence is a whole other kind of, issue on its own. But again, the goal is pretty much the same, right? Emptying in a way that is comfortable for people and doesn't interfere with your daily life, and also protecting your skin. And so that can, for various people, can look so different from person to person, and it really is kind of a trial and error and whatever works for you.
And that also can change depending on people, if they're ill or traveling or things like that, the usual things that can kind of change up. Did that answer?
Just being consistent, just like the same time every day. You know, I do mine in the evening because it can take longer. I'm not a morning person. It's easier for me to do that, and then shower, just being consistent, because if you're busy and miss, that's when you're going to have an accident. And never travel without Imodium AD, ever. So trial, I learned that the hard way. Yeah.
For me, my diet is a big part of my bowel program as well. I eat a lot of fiber, and that helps everything along. And so if I travel or I'm not as kind of deviate from my normal diet, it can have an effect as well, just at how long it takes, or even things like that. So,
Jill or Shannon, any other thoughts on kind of incontinence concerns or bowel or bladder concerns?
I'm just learning from the experienced folks.
I do carry extra pants and underwear all the time, just in case. They have come in handy a few times. Yeah. But I just
Baby wipes.
bag of tricks.
Your bag of tricks.
Oh yeah.
Excellent.
Bungee cord, extra pants. Yeah. Not for cathing though.
Yeah.
That would be weird.
Yeah, that'd be interesting.
Excellent. Is that true for everybody?
Yeah.
Do you have your extras with you just in case?
Always. Yeah.
Yeah. Always have your backup.
And there are a lot of able-bodied women I know that have the same thing. You know, they have extra pants and underwear at work, and it's just, stuff happens.
Exactly. I think it is one of those things that it's all very different, as you guys have said, but it's all similar too. So it just is a little bit more complicated than it was. So we are out of time for our video night. Please join me in thanking these guys. It's been fabulous.
Thank you for listening to the SCI Forum podcast. To learn more or to make a donation, please visit sci.washington.edu.